So during yesterday's session on biomarker-guided treatment, we were discussing why we should use biomarkers and which biomarkers we should use. And one of the main reasons why we're using biomarkers in CLL is to identify patients with high-risk disease. And today, in our recommendation, international recommendations, we do 3 different genomic markers. So it is FISH analysis to look for deletion of 17p primarily. We do TP53 sequence analysis, and we sequence the IDHV gene in order to determine the IDHV gene mutation status. So during this session we also discussed that these biomarkers were developed when we use chemoimmunotherapy primarily, but now we also have to reassess their value with the new targeted therapies. So if I go into different markers, we need to see if patients have a TP53 mutated clone, because we know that these are high-risk patients and they benefit from targeted therapies. And to identify these patients, we have to do FISH analysis to capture the lesion of 17p, but at the same time we look for TP53 aberrations with sequencing, because it can also be small point mutations. And what we have learned the last 10 years is that using the new technologies called next generation sequencing, we can also see patients that have low levels of TP53 mutations, microclones with TP53 mutation. And it has been shown that using chemoimmunotherapy, even patients with small mutated TP53 clones have a poor outcome. So that has led to the latest ERIC recommendations. Before we had a certain cutoff, how large proportion of TP53 mutation you have to have before you call it. But now we have said that this is up to each individual laboratory to validate what their cutoff is. So many laboratories now can reply even below 5% of variant allele frequency. That is how we measure the amount of TP53 mutation. And, but they have to themselves set in their sort of clinical reply what the validation cutoff is. So we know that even this small amount of TP53 can have poor impact when using chemoimmunotherapy. But it's still a question if this is the same for targeted therapies, and I think we have to collect more data in order to really address this more in a large population, so we can get a definite answer. Besides these 2 markers, we also have to do the immunoglobulin mutation status, and that we have done with the old techniques for many years, Sanger sequencing, and we are turning now into also next generation sequencing. What was discussed also yesterday is the impact of something called B-cell receptor stereotypy, where we can identify small patient groups with specific outcome. So today now, in our latest guidelines prepared by Eric, we recommend to report 2 of these stereotype subsets. Subset 2, which generally often have mutated IDHV genes but very poor prognosis. They do not respond to chemoimmunotherapy. And the other group is subset 8, which we know has a very high risk of Richter transformation. So these are news in biomarkers that we think one should add in the clinical report, along with the IDHV mutation status. Also, we were discussing genomic complexity, which we know that it is a poor risk marker using chemoimmunotherapy. It's still a little bit of a question mark if it is also for targeted therapy. And that has to be we have to follow it and see if it also is a poor risk marker. But here the problem or the challenge is that which technology should we use for measuring genomic complexity? Traditionally we have been using chromosome analysis, and then some centers, including ourselves, are using genomic arrays, where if patients have 5 or more aberrations, we report back that this is a high-risk patient. But also there is the newest way of doing it is whole genome sequencing, which is quite expensive still. And these were issues we were discussing. If we want to capture these patients that we think have a high-risk disease, what is the best technology to use? And I would say that it's still an open question, and we have to follow this in the next coming year also, when new studies are presented showing if it's still a poor risk marker in treatment or in patients, first-line treated patients with new target therapies.